I'm Kevin Tetsworth. I'm a orthopedic surgeon. I work principally at the Royal Brisbane Hospital in Brisbane, Royal Brisbane and Women's Hospital. I also work at the Wesley Hospital in Brisbane, as well as at Macquarie University in Sydney at the Limb Reconstruction Centre. And those are my clinical appointments. And I also have an appointment at the Hurston Biofabrication Institute. My qualifications, I qualified in the States originally, so I have a fellowship there in the American Academy. I also have a fellowship in the Royal College in Australia, as well as a member of the Australian Orthopaedic Association and the fellowship in the International Orthopaedic Trauma Association. Clinically, I'm most interested in managing orthopedic infections. I had an opportunity to do a fellowship with George Cerny in Atlanta, and he's the godfather of orthopedic infection management and chronic osteomyelitis. So that was before I really started my career, but got me going. So I have a huge interest in managing orthopedic infections, chronic and acute, as well as segmental bone defects, high energy trauma, limb salvage and reconstruction, deformity correction, limb lengthening. That's on the clinical side of things, as well as prosthetic joint infections. I get a huge number of infected total joints. On the research side, I have areas of interest that involve not only infection management, infection control, and limb salvage, bone defect. Reconstruction of bone defects is one of my principal areas of clinical research interest. I also have an interest in developing biomarkers for infection, and we have an active area there that's a very unique sort of thing specific to Australia at this time in the research, as well as ways to deliver bone growth hormones and growth factors that accelerate bone healing to reconstitute bone defects, as well as using 3D printed models and designing scaffolds that actually reconstruct segmental bone defects. So when you have tremendous bone loss, to reconstruct that in either growing new bone using traditional distraction osteogenesis methods, now using implantable devices instead, or transplanting in these 3D printed specific patient-specific titanium scaffolds. And finally, my other area of interest is in those limbs that we can't salvage, which end up with an amputation or are better treated with an amputation. We have a way now of doing skeletal attachment, direct skeletal attachment of a prosthetic limb, so osseointegration. And I think the reconstruction of the amputated limb is going to be a huge area of interest going forward into the future. And over the next 5 to 10 years, you will see it become extremely popular. It's quite an interesting journey that I've taken to get to this point. I think that if you see in the background, I have all these photographs from the NASA program. So I grew up in Florida and watched a lot of the rockets take off. But from there, I grew up in a small town in South Florida and elected to go to a big city up north. So I went to the University of Chicago and then stayed there for 15 years. So I was very busy and active throughout doing my undergraduate training in Chicago at the University of Chicago. Then I went to medical school at the University of Chicago. And then I did training, not at the University of Chicago, but at one of the other affiliated programs in the Chicago area. And from there, it was my good fortune to get involved in a fellowship with a gentleman, Professor Paley, who's one of the world's leading experts in limb salvage and reconstruction using the Russian technique, the Ilizarov methods with Ilizarov fixators, which have gradually evolved into implantable devices, but similar concepts. And from there, I then did a fellowship with the world's leading expert at that time. He's since unfortunately passed, but a lovely guy, George Cerny, the godfather of osteomyelitis surgery. And so I have this tremendous pedigree where I've trained with two giants in separate areas. And that allowed me to then be involved at a very high level of expertise managing the most complicated, difficult problems, which in orthopedic surgery generally involve bone loss and infection. And so those became my two areas of greatest interest. And that's why I am recognized internationally for my expertise in terms of management of those problems. And with that came this interest in doing prosthetic joint infections and doing stage management, creating articulating spacers, other devices and things. And I ended up, I practiced in the States, in Baltimore, in affiliation with not only the University of Maryland, but the Shock Trauma Hospital there, one of the world's largest and greatest trauma centers. From there, my ex-wife was from Tasmania, so we emigrated here in 2000. I've been here for 24 years. I've been largely in the public system at the Royal Brisbane Hospital, but I have recently begun to branch out and do a bit of private work, mostly to facilitate those patients who wish to do so. But because so much of it is complicated and difficult, the vast majority does take place at the Royal Brisbane or in Sydney at the Limb Reconstruction Centre. And my third good fortune was to get involved with Professor Tetsworth there at Macquarie University. And so I've been working together with him for 9 years now. It's been quite a journey in terms of my original interest, and most of my focus has been on limb salvage and reconstruction of the most complex, difficult problems with segmental bone loss, shortening, risk of limb loss. And then there are those limbs that cannot be salvaged and are better treated using amputation. So by affiliating with Winjud and learning from his great expertise in that area, he's the world's leading expert, and I am the second most experienced surgeon in terms of what we call osseointegration surgery, this direct skeletal attachment of a prosthetic limb to facilitate their rehabilitation. And it really has opened many new doors and avenues to explore as we embark on a new world of reconstructing the amputated limb using prosthetic limbs and microprocessor controlled limbs and myoneural interfaces and things. So really some interesting work there. My areas of interest in research, it's a bit of a difficult question to answer because I have so many areas of interest. I think I have close to somewhere in the neighborhood of 30 to 40 different areas of research activity involving principally, and if I group them into infection management, meaning people that have deep infection clinically, or if they have bone loss. And so we've done quite a bit on the different methods of reconstructing bone loss. And so some of my research involves what's called the Masquelade induced membrane technique. You put an antibiotic methacrylate spacer into a bone defect, you allow the foreign body reaction to naturally form a membrane around that spacer. And then when you come back and remove the spacer, it gives you an environment or a milieu that's more receptive to receiving bone grafts. So it's an interesting French technique. It's not the first time that staged management was used, but it is another method to accelerate or improve the outcomes with using bone grafts into large defects. And so my research area there actually involves, we have taken over 80 specimens from these induced membranes, and we're doing genetic analysis of the products that are produced, either upregulation or downregulation, and also correlating that with the clinical response. And that's through a grant with the Orthopaedic Trauma Association from North America. Other areas of research interest include into biomechanics of segmental bone defects and how that differs from the smaller bone defects, and how you can improve fracture fixation. So fracture fixation is a really interesting area for me. I do a lot of high energy trauma. Our other areas of research interest include, and this is where it always, because I think that segmental bone defects using these 3D printed scaffolds is another really area of active interest of mine. We were and still are among the world's leaders in that particular area of interest. And also reconstructing amputated limbs using osseointegration has become another huge area of research and interest for me. We have a number of publications in conjunction with Professor Tetsworth in Sydney and at the Limb Reconstruction Centre there at Macquarie University. So that's something that within Australia, recognized internationally as the world's leading centre for that sort of activity. And we have many different areas of research interest ongoing there. And finally, in the biomarker that's been developed, Anthony Rapisarda and others have worked to develop a panel of biomarkers. It's the first set of biomarkers that are genomic based. There is a BioFire biomarker analysis to detect infections that's come out of the UK, but that is proteomic. It's based on the proteins that are created. And the genomic marker instead looks for 7 distinct genetic responses in that environment in and around an infected joint. And it can be a native joint or a total joint, but it's proving very effective. And we've done some preliminary clinical studies to demonstrate its efficacy, but we're about to embark on an RCT to better define how that fits into our methods to detect and surveil for infection ongoing. This is quite an interesting problem because patients come to us all the time with swollen, painful knees. And then there's the question, is it from some inflammatory condition like gout or rheumatoid arthritis or other conditions? Or is it traumatic, or is it from infection? And by using this biomarker panel, it allows us to make that diagnosis very rapidly within a matter of hours. And then you can initiate the right antibiotics if you need to, because it also helps determine which bacterial organism is responsible. Or if they don't need antibiotics, then you eliminate that from their treatment pathway. So there's the cost savings, and they don't need to be in the hospital unnecessarily. And so it's an immediate way rather than waiting for cultures, which sometimes take 3 or 4 days. This is a huge advance. And I think going forward will become the standard of care throughout the world. Control of surgical site infection in orthopedic surgery is a huge issue and problem. It's one of the main things that orthopedic surgeons are constantly worried about, especially with elective procedures like total joints. Because if someone has an infected total joint, the cost to salvage or reconstruct that may cost an additional $90,000 to $130,000 US is a huge problem. And also the impact on the patients and the risk of amputation or death. Their mortality rate is so much higher in that initial year, and subsequently over a 5-year period, they have a higher rate of mortality if they have a prosthetic joint infection. So how do we minimize that risk? Well, in the 19th century, we identified hand washing by Semmelweis, and then later Halstead introduced the concept of sterilization of instruments and things. So that was the 19th century. The 20th century introduced antibiotics, discovered in 1928 by Fleming, and then later on, introduction of biocompatible alloys and materials that we could implant into the human body that didn't elicit an inflammatory response. So this was the 20th century, and we perfected that over a long period of time. I think that in the 21st century, now we are starting to have better antibiotics, certainly a much broader range of antibiotics are available, but also doing things to modify not only the environment, meaning create a sterile environment in the operating room, but also do things to modify the patient. So patient modifiable factors become an important issue. One of these, you may or may not realize it, but we are all walking, talking petri dishes. We are colonized with bacteria up and down, and trying to control that. One way is to pre-screen patients. So do nasal decolonization or pre-screening for the presence of methicillin-sensitive Staph aureus or methicillin-resistant Staph aureus. These are 2 of the main organisms that we worry about. But doing decolonization, doing prep of the skin before they come into the operating room for a period of perhaps 24 to 48 hours ahead of time. These have been shown to be effective. Other modifiable factors would be to decrease their weight. So a patient with a BMI over 40 has a much higher, I think at least 6 times higher risk of having an infection. The other things are having specific dressings in the early postoperative period, having antibiotics that are specific to the wounds and things that we deal with most, introducing local antibiotics into the wound. These are various things that have been attempted and have some benefit. I think another one is in the diabetic is monitoring their HbA1c. So a patient with an HbA1c under 7.5 is a reasonable risk to consider for elective surgery. Over 7.5, the risk is too great, and so you do things to try and minimize that. And finally, I think that the introduction of triclosan-coated suture is certainly a new area that many people haven't noticed yet, but the data has accumulated. I know that there's a number of papers, the David Leeper paper, I think that appeared in 2019 in the BMJ Open, and that showed that looking at a meta-analysis, that there was a 27% risk reduction if you use triclosan-coated sutures. This is for clean or for contaminated surgery, meaning open fractures and things, either or. A 27% reduction in the risk of surgical site infection. Now, it was part of my role 2 years ago while I was involved in the US. I play a role internationally, perhaps more so than in Australia, but on the Orthopaedic Trauma Association, together with the American Academy and the Department of Defense in America. We created a working group, and I was co-chair of the working group on reducing surgical site infection associated with open fractures and high energy trauma. This is the area of trauma that we worry about most, wounds that we have to undertake to fix fractures after they've had high energy trauma or open fractures. And in those sort of situations, minimizing this risk of surgical site infection, you can't change their HbA1c. It's impossible. It takes several months to do so. They need surgery right away. You can't stop them from smoking. You can't change the BMI. So there aren't very many modifiable risk factors. So then we get into this area of, well, how quickly do you close the wound? What do you cover it with? What antibiotics are useful? And again, triclosan-coated sutures, I think, have a role there. Not anything that's been documented yet in RCTs, but it's something that we've introduced into our practice, as well as the other simple thing is if you just change your gloves before you start to close the wound in any surgery, and this has been shown in general surgery and in O&G. It hasn't been shown in orthopedic surgery yet. I'd like to do the RCT, but this is another thing that you can do. It's a simple, easy, fast thing to do. And so these are the measures that we take in orthopedic surgery, both elective and trauma surgery, to try and minimize the risk of developing a surgical site infection. Becoming an orthopedic surgeon in Australia, it's very competitive. It's hyper competitive. We have so many excellent candidates. And so part of that role or part of the process of applying, you need to have good support around you. I think that that's an important side of things that many people neglect. Trying to do this alone, it can be difficult. You need a good partner, you need family support, you need others who can help you through the journey, because becoming a non-registered trainee, so what we call a principal house officer, a PHO, as it's called, sometimes takes 5-6 years before they get on the training program, and that's hyper competitive. I think that having an interest in orthopedic surgery, as many do, certainly is an important aspect. But really, it is being very organized in your approach, trying to plot out how you respond best to the various obstacles that are put in place by the selection committees, and doing some research seems to be an important consideration, but more so, you need to have good social skills. You need to be very good in terms of how you manage patients and manage also the interactions, the many complex interactions that you have in your everyday with the nurses, the staff, the other doctors, your colleagues, your peers, your superiors. All of this ultimately does play a role in whether or not you are successful in your application to become an orthopedic surgeon. It's surprising how difficult it is. I see so many excellent candidates that unfortunately don't make the grade for whatever reason. It's sad to me, but That's the reality.